The concept of surveying dates from about 1900, and like most good ideas, is very simple. The concept is based on the establishment of parallelism as an aid to denture design. However, surveyors are very versatile instruments and have an important role to play in modern dental practice. The object of this programme is to explain the rationale behind the use of surveyors and how their use can enhance the quality of dental care that we provide for our patients. The earliest surveyor consisted of a table on which a study model could be placed and moved around a fixed vertical pencil marker. However, as time went on, this was found not to be very practicable, and the modern surveyor was developed. This consists of a base plate and a vertical column from which a hinged joint is cantilevered. This cantilever carries a movable vertical rod parallel to the column, and on the end of this rod, various attachments can be fixed. There is also a table to retain the study casts in position, and this table can be moved over a wide range of positions to enable the clinician to design the best appliance for the patient. When purchasing these items, we should look for sturdy joints that are free from shake, a multiple position tilting table, and a means of securing the study casts to this table easily and firmly. On the earliest surveyors, this was achieved using adjustable claws or screws, as on this surveyor. But more recently, magnetic tables have become available, but this requires the incorporation of a steel plate into the base of study models. Modern partial denture work, particularly that involving the provision of chrome cobalt cast metal bases with suitably designed clasps to provide retention, cannot be satisfactorily achieved without the use of a surveyor. I would argue that it is the responsibility of the clinician to design his own dentures, rather than to abrogate this responsibility to his technician. Though it must be admitted that in the United Kingdom in 1979, only 10% of chrome cobalt denture bases were designed by dentists. Nevertheless, there is a strong case for saying that a dentist should design his own dentures. Let us now look at how the surveyor can help us in that task. In the usual stages of denture design, the clinician will have outlined the saddle areas and decided which tooth or teeth need replacing on the denture base, and will have planned adequate support before moving on to surveying. The first decision to be made is to choose the line of insertion and withdrawal of the prosthesis. This is dependent on the number and inclination of the missing teeth, but here are some simple rules for you to follow in the first instance. In the case of a distal extension base, we alter the line of insertion and withdrawal so that it is parallel to the distal surface of the last standing tooth. Like so. In the case of anterior saddles, we tip the model so that the relative labial undercut can be used to help to resist displacement forces on these dentures. Like so. In both cases, therefore, we are using undercuts relative to the path of displacement to resist denture displacement. In the first case, the distal extension saddle, we're using the tooth. And in the second case, the anterior saddle, we use the alveolus to resist displacement. In the case of common denture types, particularly single or multiple bounded saddles, it is a matter of choosing the best compromise line of insertion and withdrawal. Depending on the degree of tipping and rotation of abutment teeth. And usually this will become obvious from a close examination of models. Once this line of insertion and withdrawal has been decided, we lock the surveyor table and transfer marks to the casts in 3 places. One, 2, and round the back for the 3rd. This is an essential and often overlooked item, without which your technician will be unable to duplicate the line of insertion and withdrawal that you have laboriously established. Because pencil marks can so easily be rubbed off, or felt tip marks run, it is well worth scribing the marks into the land surrounding the border areas with a sharp knife to give a permanent record. For the next stage, you'll see what I'm doing more easily if I use a large tooth. So let's change to a large tooth. Like so. The next stage is to mark the abutment teeth at the established line of insertion and withdrawal. With a pencil in the surveyor chuck to delineate the maximum bulbosity of the crowns of the teeth and to divide the surface into the area coronal to the survey line, the suprabulge, and the area below the survey line, the infrabulge or area of undercut. In order to obtain retention of the denture base, we must place the tips of our clasps into the infrabulge area. The survey line firstly gives us the important information of where the undercuts are, and secondly dictates our choice of clasp. But it doesn't tell us where that clasp tip needs to be placed. Let us look at some typical survey lines and see how these lines change as we alter the line of insertion and withdrawal. I shall take a lower molar tooth, place it on the surveyor table at the chosen line of insertion and withdrawal, and survey. So, tip the model forwards, resurvey, tip the model backwards and resurvey. Like so. And let us look at the result. For clarity, I've had the lines redrawn in 3 colours on a second model, so that you can see how altering the line of insertion and withdrawal alters the survey line, and with it the shape of the infrabulge area. You can also see the area that is commonly infrabulge, whatever our 3 lines of insertion and withdrawal. It is into this area that the clasp tip is to be placed. We must also be aware of the sequelae of losing teeth. Posterior teeth tip and drift, and in the case of molars, sometimes rotate around the palatal root for maxillary teeth. and this has an important bearing on the survey line. Let us see how this affects the survey and look at the change that has occurred. We'll again look at large models, see a tooth that's been surveyed vertically and a tipped tooth. If we look carefully, we can see that at the mesiobuccal cusp, the survey line of the tipped tooth is very much higher than on the tooth with the correct axial inclination. These changes have an important bearing on our choice of clasp. But first of all, let us remind ourselves about clasp function. The clasp may be divided into a standing, non-flexible 2/3 and a retentive flexible tip of 1/3. When considering clasp function, it is the flexible 1/3 tip which should be placed into the infrabulge area, and the standing portion of the clasp placed suprabulge. Otherwise, the clasp will not function efficiently. The elastic modulus may be exceeded, and the clasp will fracture or distort in use. Our clasp may be applied to the teeth in one of two main ways, either occlusally approaching or gingivally approaching. Which approach do we use? Well, that depends on the survey, so let us see how we might allocate clasps to survey lines. Although many different types of clasp exist, and there is a considerable profusion of variables, we are able to make satisfactorily retained chrome cobalt dentures using very few clasp types. The ring clasp is particularly suitable for single standing molar teeth, and because it grips circumferentially around the tooth, it acts as its own reciprocal. We must also remember that molar teeth are inclined on the curve of Monson. As we can see, the natural undercuts occur buccally on maxillary teeth and lingually on mandibular teeth. This clasp is extremely versatile and is particularly indicated for tipped and rotated molars. The greater the degree of tipping, the higher the survey line comes onto the mesiobuccal of the molar, and the greater the indication for a ring clasp. You will note that the retentive tip of the ring clasp on this maxillary denture is placed at the buccal side of the tooth. In contrast, for this mandibular denture, the retentive tip is placed lingually. There is, however, one common fault that has crept into the use of this clasp, and that is the placement of a rest distally as well as mesially. So if we look back at the model, placing a rest just there. Such a distal rest is deprecated because it adversely alters the normal ratio of 2/3 standing portion to 1/3 retentive clasp tip, as it is from such a rest that we would have to redetermine the effective clasp length. The next clasp to consider is the 3-arm clasp. The elements of this occlusally approaching clasp consist of a buccal retentive clasp, a rest, and a lingual or palatal reciprocal. There is little difference functionally between this clasp and the single-arm buccal clasp, as this next denture shows. Although in this latter case there is coverage of the gingival margin, and this may be less conducive to the maintenance of long-term gingival health. These clasps are most useful anteriorly and also posteriorly when the posterior abutment tooth has further teeth in contact posteriorly. Gingivally approaching clasps, and let's look at one on this model, are brought forward from the saddle area the saddle part of the base plate and have a variety of different shapes of tip. The flattened end, the T shape, the L shape, the I bar. It is a common finding that the T-shape ending is a very unaesthetic clasp. Considerably improved aesthetics, together with adequate retention, can usually be achieved using correct positioning of the I-bar type of clasp. The most important decision we have to make is which clasp to use on which tooth, and this is dependent upon the survey line at our established path of insertion and withdrawal. You will remember how clasps function and the important relationship between standing portion and free retentive tip. With this in mind, let us look at two different survey lines and determine how they affect our choice of clasp. In this first example, the survey line is low at the distal surface on this lower premolar and high mesially. Because we are able to place the standing portion in the suprabulge, this survey line indicates we should use an occlusally approaching clasp. In this second example, the survey line is very high at the distal of the tooth and lower mesially. Because the survey is so high at the distal, we are unable to place the standing 2/3 of the clasp in the suprabulge area. This survey line indicates that a gingivally approaching clasp should be used. The alternative approach, as this sample denture shows, that of bringing an occlusally approaching clasp from the mesial surface, is not satisfactory. Although the denture base might seat on the model, in clinical practice it is often difficult to achieve full seating on the tooth. Usually the denture fails to seat down in this region. Additionally, the act of bringing the clasp over the interproximal embrasure will, in the vast majority of patients, interfere with the occlusion. So why do it, when the gingivally approaching clasp offers such an easy alternative? In an earlier part of this program, we established by survey the area of the tooth into which the clasp tip ought to be placed, and we've just established which clasp to use and why. This information is still not sufficient to enable us to design the optimum denture, because first we must establish the correct positioning of the clasp tip in a horizontal plane. Let us consider these two teeth, which are shown in faciolingual section, both of which have identical survey lines but different infrabulge shapes. If we place the tip of the clasp in the same vertical position on both teeth, we shall occupy twice the horizontal undercut in tooth B as in tooth A. But is this correct? This can only be answered by looking at the choice of material from which we can make our clasp. Understanding the material's performance, and particularly its elastic modulus, and considering the different degrees of flexibility of occlusally approaching and gingivally approaching clasps. Occlusally approaching clasps are less flexible than gingivally approaching clasps, and cobalt chromium less flexible than gold. With this in mind, let's look at the different degrees of flexibility that we can employ for placing our clasp tip. So that because occlusally approaching cobalt chromium is the least flexible, we should only place the tip of the clasp into a horizontal undercut of 0.25 of a millimetre. For gingivally approaching clasps, this can be raised to 0.5 of a millimetre because they're more flexible. And indeed, with gold, because it again has a better elastic modulus, then we can use slightly greater horizontal undercuts of 0.5 of a millimetre for occlusally approaching, 0.75 of a millimetre for gingivally approaching. So, with these figures in mind, we can establish the correct amount of horizontal undercut into which the clasp tips must be placed in order to function optimally. It follows, therefore, that as an essential part of our denture design, we should use the appropriate horizontal undercut gauge to establish the precise position into which we want our technician to place the clasp tip, and mark this position on the model during our design stage. So let's change from this large tooth to a model of a patient, and we can then look at the positioning of the clasp tip more closely. But first of all, I shall have to align this model to match the survey lines that we've previously marked. You remember the 3 vertical marks that enable us to line up with later. And we can then lock off in that position and change to the undercut gauge. In this case, because we're using an occlusally approaching ring clasp on this rather tipped molar tooth, we want a 0.25 millimetre horizontal undercut gauge. So we can then place that into the undercut area, line against the tooth, and having done that, make a definite mark exactly where we wish to have the clasp tip placed. We have said earlier in this programme that surveyors are very versatile instruments, and we have just seen how, suitably used, they can assist in the design of removable partial denture frameworks. They have, however, other roles to play in the construction of partial dentures. It is a common finding with an acrylic partial denture that when it's received from the laboratory, it doesn't fit the patient's mouth, because acrylic has been processed into undercuts at the finishing stage. Removal of this excess acrylic can be very time-consuming and can cause annoyance to the dentist and the patient, and can hardly be said to create a good impression when the first thing that the dentist does to get the denture to fit is to grind bits away. Such problems can simply be avoided by instructing the technician to plaster out and check on the surveyor all undercuts relating to teeth prior to processing the denture. This then is how surveyors can be used when the dental hard tissues are being considered. However, we must also consider how the surveyor can be used to delineate soft tissue undercuts. This is particularly so in relation to anterior saddles. Firstly, by establishing a survey line along the saddle area at the chosen line of insertion and withdrawal of the denture, it is possible to determine whether there is sufficient room so that a labial flange can be placed, or whether it is necessary to gum fit the teeth, as this sagittal section shows. The survey line along the saddle also marks the position of the maximum bulbosity and demarcates the level beyond which the acrylic work should not be taken. It is all too easy for the technician to overextend labial flanges in this area. This will prevent the denture seating in the mouth once the acrylic resin has been processed on. This potential problem is often overlooked during the try-in stage, as the wax flows and allows the denture to seat down. These laboratory procedures can be supplemented by asking for the return of the denture on a duplicate model. And by the adoption of these procedures, considerable surgery time will be saved and the standards of your prosthetics enhanced. When the abutment teeth are to be crowned, maximum opportunity exists for the creation of guide planes in the restorations. Guide planes are also valuable proximally in defining a single path of insertion, which incidentally improves retention, and for eliminating potential food traps between a denture base and an abutment tooth. Guide planes should be straight occlusogingivally, but curved buccolingually and mesiodistally. Proximally, they should extend to within 1 millimeter of the gingival margin to prevent a stagnation area. Ohowever, for tooth and tissue-supported partial dentures, the proximal guide plane should be no longer than 2 to 3 millimeters occlusogingivally, and sufficient space must be available for the proximal plate to rotate into when the denture is displaced towards the tissues. Where it is intended to incorporate guide planes into the palatal surfaces of maxillary crowns, the preparation should be finished to definite chamfer margins. It is rarely necessary to provide shoulder margins because the axial divergence of the teeth increases the space available between two contralateral teeth for the development of guide planes within the crowns. In the mandible, the reverse situation applies. It is a common problem to find mandibular premolars inclined lingually, sometimes to a marked extent. Provided that dentine is not exposed, the lingual overhang may be reduced by simple grinding. With more severe undercuts, the premolars can be recontoured with full or partial veneer crowns to provide lingual guide planes, taking care to avoid exposure of the lingual pulp horn during tooth preparation. The master casts are mounted on an articulator using a split cast technique. Let's have a look at that. You can see that the working maxillary cast is removable. The master casts must be removable since they will be placed on the surveyor table. Removal of the entire cast, plaster and mounting plane assembly from the articulator is not usually satisfactory because of the difficulty of holding it firmly on the surveyor table. The wax patterns are made on the dies of the master cast, and the contact areas and occlusal surface developed. The master cast is then placed on the surveyor table and the required guide planes carved parallel to the selected path of insertion using a wax carver in the surveyor chuck, taking care to establish the correct lengths of the interproximal guide planes. The lingual guide planes on maxillary crowns usually have to be associated with ledges because of the inclination of the maxillary teeth. Finally, the buccal retentive area should be created using undercut gauges to obtain the exact degree of horizontal undercut at the correct distance from the gingival margin. In premolar and canine teeth, this distance is usually as little as possible to avoid an unaesthetic appearance. When the crown has a facing, the retentive tip of the clasp should rest on gold rather than on the facing. Ideally, and when aesthetics allow, the entire path of insertion of the retentive tip of the clasp should be on gold. It is essential that the crown is not made excessively bulky in order to produce the required degree of undercut. Rather, the undercut may be enhanced by means of a small depression at the point of retention. When the crowns have been cast, they can be replaced on the master cast and then all guide planes and undercuts rechecked on the surveyor, and finally defined by milling in a special surveyor with a drill attachment to give this finished result. Remembering that we're looking at a maxillary cast that's just been finished on the surveyor table, so that you can see the ledges and the parallel lingual guide planes that have been established by final milling. In recent years, there has been an explosive growth in the use of precision attachments inserted into crowns of abutment teeth as a means of retaining both patient and operator removable partial prostheses. It is usual to find that at least 2 and sometimes more attachments are required, and in order to seat and withdraw the appliance, the attachments must all be set up parallel to each other, and this requires the use of a surveyor. As there are many different types of attachments, special mandrels, appropriate for the attachments to be used, are placed in the surveyor chuck and used to carry the chosen attachment into place on the abutment crown, where they can be finally soldered into position. Such sophisticated dentistry would not be possible without the use of a good surveyor. Surveyors are very simply conceived aids to dentistry, without which it is not possible to carry out adequately the wide-ranging and specialized forms of oral rehabilitation and reconstruction that are currently possible